Good morning, everyone. This is the second conference call between the Medical Society of Virginia and the Virginia Department of Health in response to COVID-19. We sincerely appreciate your attendance on the call today. It will be me. I'm Dr. Clifford L, President of the Medical Society of Virginia, and Dr. Avula from the Department of Health. Before we dive in, I wanted to share a few things that may be of use going forward. First, the MSV has been pulling as much relevant information related to COVID-19 as we can, including information from the AMA, Virginia Department of Health, and others. All that can be found on the msv.org website. I will also post a recording of this call on that webpage later today, should any of your colleagues wish to listen. Second, we expect to have over 200 people on this call and have collected questions from around dozens of MSV members over the past few days. We understand everyone has questions, so if you don't hear a question you need to answer, please use the chat function on your computer. If we still don't get to your question by the end of the call, please email governmentaffairs@msv.org. Third, we're going to try to make some version of this call weekly event during this crisis. We haven't finalized all the details yet, but please be on the lookout for another call next week. I would like to just say at the outset that the fact that we're having this call is a measure of success. This is one way we expect to be able to communicate with physicians, but particular leaders of the groups around the Commonwealth. Most of the physicians who are employed by systems will get some of their info this way, but the private groups in particular, we expect to be able to use this communication link. Now I'd like to introduce Dr. Danny Avula. He is the director of the Richmond and Henrico Health Department for VDH. Prior to that, he served as the director of the Richmond City Health District. We sincerely appreciate his and his team's time today. I know we brought some colleagues with him this morning, so I'll ask Danny to introduce them, and then we'll start peppering them with questions. Danny?
Yeah, good morning, Dr. Dale. Thanks for having me. I'll just, as I talked to Dr. Deal and to Clark over the last couple of days, I just thought it'd be helpful to have a couple of my colleagues on board with me. First, Dr. Melissa Viray is our Deputy Director at the Richmond and Henrico Health Departments. Dr. Viray is an infectious disease doc, a former CDC EIS officer, and really the main point of contact for many health systems and health providers as we've been trying to navigate folks through the testing process. And so just has a lot of hands-on experience over the last month with, what situations should be tested, what shouldn't. We've also asked Dr. Philip Nyberg, who is a new addition to VDH. He is a retired pediatric infectious disease doc who spent the bulk of his career in global health at the CDC and then for a think tank in Washington. And he's just come on recently, very recently in the last couple of days to try to help us stay abreast of some of the latest literature that just keeps coming out in journals every day. And there's a small chance that Dr. Norm Oliver, who you all know as our State Health Commissioner, might be able to join us this morning too. So I'd just ask Dr. Oliver, if you do get on and can jump in on a couple questions, that would be wonderful. All right, I'll pause there.
Okay, perfect. Danny, question one. Patient comes in and says they think they have COVID-19. What do you do?
So if they come in and think they have COVID-19, I would say, the staff that are interacting with that patient need to be in PPE and then should interview the patient, see if they have symptoms. And then if your practice has the ability to test, then go ahead and test with the guidance around what types of swabs and viral media have changed very regularly, but they've expanded significantly. And then put a mask on the patient as well. That's not the guidance that's being given out, certainly by the health department. As people call us or ask us, we are really encouraging folks who have mild symptoms right now in this context where we don't have a lot of access to testing. We are asking them to stay home and then to call their provider and see if their provider is offering testing. And if they're not at this time, to stay self-isolated so that they don't risk exposing other individuals.
All right, thanks. Next question, how do you get a test for a patient?
So there are a few options, given the fact that over the last 3 to 4 weeks, we have had pretty limited access to testing, initially just through the CDC. A few days after that, the state lab, DCLS, developed testing. Right now, there are about 400 test kits at DCLS. So if you meet certain criteria, and I'll ask my colleague Dr. Viray to just pipe in on those just because they're changing every day, but if you meet one of 3 or 4 criteria, our epidemiologists will work with the healthcare institution or healthcare provider to facilitate testing for that patient. Now, if you don't meet those criteria, that doesn't mean you can't be tested. It just means that DCLS won't do the testing. And in fact, any healthcare provider can swab the patient themselves and send the test to LabCorp or Quest, and pretty soon there'll be a couple of other options. From what I can tell, the turnaround time on that testing is about 3 days right now. Melissa, is there anything you could add to that, or maybe detail the criteria for testing?
Sure. Few things for DCLS testing or state lab testing. There are currently 3 criteria which were promulgated about middle of last week. The first criteria being an individual who has who is a close contact to an individual with laboratory confirmed COVID-19 in the last 14 days, and they have fever or signs of a lower respiratory illness. Number 2 is an individual who has fever and either clinically or radiographically diagnosed pneumonia, who has been admitted to the hospital, who's negative for who has either a respiratory viral panel that's negative or a flu that's negative, and there is no alternative diagnosis. And number 3 is an individual who resides in a nursing home or a long-term care facility who has fevers and symptoms again, who's negative on workup, who's negative flu or again respiratory viral panel negative, actually flu or flu, who has a respiratory viral panel that's negative, and again no alternative diagnosis. These 3 are the criteria that we're using to really hone in on the ones that we are most concerned about with regards to state lab testing. And again, like Dr. Avula mentioned, if there are others, there are certainly others who would meet criteria for the CDC for testing, but we are asking that this gets sent to a commercial lab.
All right, thank you. Does a positive flu test rule out COVID-19?
For these purposes, I mean, sorry, this is Danny. Yes, if you have a positive flu test, we are ascribing symptoms to the flu. Technically, it is possible to be co-infected, but as all of us, it seems very unlikely to be co-infected. And if we have a flu positive test, we would ascribe it to that. I don't know, and Melissa can maybe speak to this, I don't know if there are cases where we are testing for COVID-19 on top of a positive flu, perhaps in a situation where they have had a clear contact to a confirmed COVID-19 case.
Right, we have not, there are instances with other respiratory viruses where we have tested for COVID-19 as well. So depending on the situation, if the respiratory virus panel has something like rhinovirus or something, we have also considered testing for COVID-19. We do, as Dr. Avula mentioned, it is, although co-infection has been, can happen, it's unlikely enough in these instances that we are, again, prioritizing testing and for those individuals who are not flu positive.
All right, next question is relates to a question from OBGYN. Someone is near the end of their pregnancy and they have symptoms of COVID-19. These women often are admitted. There was some concern that whether they should be on an OBGYN floor or somewhere else. What do you think about that?
I think that the prospect of nosocomial infection is, or spreading infection through hospitals is a great concern to hospitals across the country. I think if they start to develop symptoms of COVID-19, then an isolation procedure, and all hospitals have adapted, to some degree, what they're doing. I don't know how possible it is to, maybe move that patient to the COVID-19 floor. or if this becomes, you know, extensive enough that there's a section of the OB ward that's sectioned off for this. But the same, obviously, isolation and PPE procedures would need to be put in place.
All right, thanks. All right, next question is about pediatrics. How best to treat pediatric patients?
How best to treat them, did you say?
Yes.
Well,
Or ask that to evaluate them.
Yeah, so again, right now in this, there's a lot of feedback. I'm wondering if there's anything I can do to cut that down.
Yeah, Dan, that's me, Phil. I'm still trying to get on. I'll be there in a minute.
Okay. In the same, well, Phil, if you want to speak to it, it's mostly just a phone call. I'm not on the video cast.
We're 187. Yeah, people have joined.
Okay, well, I'll jump in on that. This is Danny. So how best to evaluate and treat pediatric population? You know, the good news is that for the most part, younger kids are showing very mild illness. The same guidance that I offered earlier, which is, you know, if a child or an adult has mild symptoms, then stay home. If you have reason to be tested, you think you were exposed, then call your healthcare provider and see if they are offering the test. Make sure if they are that you're masked when you bring your child to the clinic, or that your child is masked, and that the staff can be ready to receive you with appropriate PPE. I know that this is putting a really significant burden on pediatric and adult primary care practices across the board, and you know, I'm happy to talk and later about what we can do to divert sick individuals away from primary care, because I know that it's causing exposures that are requiring you all to self-quarantine, and pretty soon we're not going to have enough staff to meet the demand. And so we're actively thinking through, you know, what infrastructure do we need to be building, and thankfully health systems are moving in this direction as well, to provide testing opportunities that don't put the rest of the healthcare workforce at risk.
All right, thank you. But I just want to confirm that you said earlier that to treat COVID-19 patients, you need to be in PPE, which would include a mask.
That's correct. Yeah, I mean, the CDC guidance around appropriate PPE for this is still N95, gloves, gown, and face shield.
So next
I will
question
add
is
to that. Oh, sorry. If I could just interrupt there. One more recent addition to the PPE guidance from CDC is that they acknowledge that in this time where N95s are difficult or respirators are difficult to get a hold of, in those instances, and because of that, they are allowing for the determination that surgical masks would be you can use a surgical mask in place of an N95 and be considered be considered in the same way protected. Specifically, if you're not doing any aerosol generating procedures, intubating, eliciting cough or anything like that, then a face mask in this environment of decreased N95 availability would be considered appropriate.
All right, thank you. So that's what I hear you saying. The surgical masks, in a lot of cases, would be okay instead of an N95 in the office setting.
Right, and down the road when we're back to our normal operating procedures, ideally, yes, you want an N95 mask. But given that we don't have them available, CDC has made the determination that it would be acceptable to use a surgical mask.
All right, perfect. Next question is, how do we get masks? We hear stories out of Roanoke of providers doing procedures without masks because they're being hoarded.
Boy, that's a tough one. So I know that there has been an ask several weeks ago from the state to the CDC for an allotment of the strategic national stockpile. which includes a bunch of masks and other PPE. I do think Dr. Oliver is now on. He texted me and confirmed that he is on the call. Dr. Oliver, are you available to answer that question?
Yes, I am. Do you guys hear me?
Yes, thank you. Thank you.
Hi, this is Norm Oliver, the State Health Commissioner. First of all, I want to thank Danny, Melissa, and all the other folks in the local health departments who are the ones who are really on the front lines for VDH and helping community-based practitioners and hospital systems deal with this crisis. And they're really doing the lion's share of the work. As Danny mentioned, we put in an order very early on in the crisis to the Strategic National Stockpile. We received the other day about 100,000 or so N95 respirators, a lot of surgical masks, gloves, gowns. I do have to say that we received about 5 to 10% of what we actually requested. And the reason is that we weren't the only ones who requested it. All 50 states requested the same amount or more of these of this PPE, and HHS kept back about 50% of the stockpile. They held it in reserve because we're all well aware of the fact that we have not reached the peak of this pandemic in the U.S. Yet, and they want to keep some things in the stockpile. So we still have a limited supply. Through the regional hospital coalitions that exist in 6 regions around the state, we are going to be distributing these PPE to hospitals. I would encourage practitioners who are in private practice and not associated with hospital systems to reach out to those coalitions. You can, all the health departments have connections with them and can help direct you to those people. And to the extent that we can, we will be getting this PPE to you. There is a limited supply, and we will however, we're prioritizing hospitals and practitioners. So that would be the way to go about getting it. I also should say that we're doing our best to encourage our federal partners to really get the manufacturers to step up the manufacture of these materials. So hopefully down the line we'll have more.
All right, thank you. I'm going to switch another question I was getting online, which was that if you're a provider in your private practice getting calls from patients who'd like to be tested, like you answered the first question, who do they need to be? How do we to call and get to put on the wait list to provide the test in our own office?
To provide the test in your own office. So that would be a conversation with whoever your lab provider is. So I've been on the phone this week with clinicians who have all been talking to their LabCorp representatives. LabCorp has about 2,000 test kits right here in the central region that they've been distributing. And that's challenging to some degree because it means that they're doing deliveries in 5 test kits here, 10 test kits there. Some larger health systems have been able to get larger allotments, but that's kind of what LabCorp is dealing with this week, 2,000 test kits that they're looking to deliver. You all have heard the federal announcements that they're going to make 1.9 million test kits available this week. We have yet to see that hit the ground, but the hope is that very soon there will be many more test kits available. But yeah, so if you do lab testing through LabCorp or Quest, then that would be where I would start. However, there are also other providers of the transport media and swabs. And in fact, I was just talking to Jake O'Shea the other day, and he said that there's new guidance that you could actually use any synthetic tipped swab in normal saline. So I'm looking for that guidance, and we're pulling together whatever the guidance is around test kits, because it's possible that a lot of the test kits you all have on hand for flu or HSV might suffice for this. And so I'm happy to send that over, at least what we have pulled together so far, and to send that out to the MSV distribution list.
All right, next question. So if a patient is positive in your office practice, do you have to close your practice? What's the protocol?
I mean, if folks have been appropriately PPE, there's no reason to close the practice. I think we're quickly getting to a point where this is so widespread that we're, most practices are going to see one, if not many, patients with COVID-19. So hopefully, if everyone is appropriately PPE'd, then the patient gets their diagnosis and is told to self-isolate at home until they are fever-free for 72 hours, or they have complete resolution of their respiratory symptoms, whichever comes first, whichever is longer.
Yeah.
And sorry, go ahead, Melissa.
Sorry, I was going to say, to clarify on that one, it's or 72 hours from the fever without any kind of Tylenol on board, or 7 days from their onset of symptoms, whichever is longer.
Great, thanks.
So one of the other questions I'm hearing online is how far from patient zero do you have to be away to be quarantined? For example, patient zero is positive and one person had a close contact with them, and patient two had a close contact with that person. I mean, how far out are we going with this before you have to be quarantined?
Yeah. Right now,
we're hearing that a lot. Yeah. Go ahead, Jay.
Well, let me just say, and then Melissa, because she's been providing most of this guidance, can certainly expand on that. What we have been doing is in our epidemiologic investigation, figuring out who have been the close contacts, who's been, within 3 to 6 feet of the individual for extended periods of time, and that we are not quarantining second ring contact. So a contact of a contact. And so anybody who falls into that first ring would be asked to self-quarantine for 14 days. What would you add to that, Melissa?
I know, I would agree with that so if the person who is exposed is asymptomatic and has not developed symptoms, individuals who were contacts of that contact before they went into quarantine don't need to necessarily also go into quarantine themselves. I will add the one nuance to that is that there are individuals who are pending testing, and in some of those cases, I won't say this is happening globally because I don't think it's it's not necessarily applicable globally, but if there is an individual who's a particularly high risk person for acquiring COVID-19 and they are pending testing, and or their contact is someone who, for example, works in a long-term care facility, we may ask that close contact to a pending test to, as much as possible, aggressively social distance and try not to be around because of their particular occupation or because of the particular high risk of the individual to whom they were exposed. But in general, it's just for those who have exposure to confirmed COVID-19 cases.
All right, thanks. So one question coming in is, what do you do if you don't have PPE? Is there any way of organizing groups to share if they have an abundance of PPE to share?
I don't know that there's anybody who's in the abundance camp right now. I do think just yesterday that maybe there are opportunities to look outside of the healthcare industry for this. For example, I was contacted by, I don't know, they're like a designer or building company, and they said, hey, we have N95 respirators. We'd be happy to donate to healthcare. It was a small number, and we had them send those over to the Daily Planet because they are actually standing up community testing. They started yesterday. So I think maybe one of the things that we can do as VDH is do an all-call outside of the healthcare industry for relevant PPE that might actually be helpful.
And I will say
Thanks.
the nuance on that one is that not all, in particular, I think it's a very good idea that we are starting to reach out to our non-healthcare partners. I think the nuance to that is we're going to have to make sure that the respirators that they have are the ones that have been evaluated by FDA for use in medical care, because there are a large number of respirators that are their FDA is looking to expand in an emergency situation FDA clearance for certain respirators to be used in medical care, given the shortage. But there is, we just need to make sure that as as you're doing that and you're reaching out to your partners in non-healthcare settings, that what you get from them is on that FDA list of respirators that are not necessarily medical grade N95s, but that we have in the situation cleared for use.
All right, thanks. So one question, is there really an age threshold where we shouldn't be testing, say, kids under the age of 6 or 10 or 12 for COVID?
There is not.
Yeah, I think that. Sorry for getting on late. I think the answer is it depends on the circumstances. That if it's a situation where you're concerned about a kid spreading, then because it's part of a family cluster, then it probably is worth testing. There are lots of children are more likely than adults, and maybe you talked about this before, but children are more likely than adults to be positive, be contagious, but be asymptomatic. So it depends on the risk of spread. Beyond the clinical concerns, it really depends on the risk of spread.
All right, next question is a specialist question. If you come in for a visit, for example, your urologist, orthopedic surgeon, and tells the office staff or doctor that they think they're sick, what's the best way to handle this? I think I know what you're going to say, but
immediately mask the patient and tell them to go home and call their primary care provider if their symptoms worsen and warrant testing.
All right, next question is a little more financial, which is med mal insurance renewals are in July, lots of new risks and prices likely to jump. Any conversation or consideration of extending the renewal period or keeping costs at current levels?
I'm going to pitch that one to Norm. I don't know if there's been any conversation with the state about that.
Yeah, so this is Norm Oliver again. The governor actually has been in conversations with insurance providers. I don't know where that stands yet, but that's certainly something that's on the table to be negotiated. We definitely want to do what we can to protect providers, and this would fall into that category, and I'll be sure to raise this point with him and the Secretary of Health. I know that things have been done in other regards for around unemployment insurance and other things to help protect people during this crisis. So I think we can do something in that regard, but I don't have any specific answer right now, but I will take that to the governor.
All right, thanks. Here's either two more testing things. One, Jake O'Shea sent me a note and said third-party labs have not confirmed that they can accept sterile saline yet. But the next question is there any way to reduce the amount of media required or use up OP swabs?
Yeah, so the LabCorp site at least has some very specific guidance about what types of kits they'll use. And again, I think everybody is trying to figure out how they can make test kits go further. For example, putting multiple swabs from the same patient into the same media and sending that over. So that guidance document that we're pulling together has some links and information about that. I don't know the specific answer to that question off the top of my head, but I'm happy to consult the folks on my team who have been assigned to this and then send that list to MSV for distribution.
All right, this is coming back. I'm getting a lot of pediatric questions, and then just reiterating about in terms of recommending duration of isolation for pediatric patients with mild symptoms. And assuming that we don't have the ability to test an adequate PPE, is there a recommended duration of isolation?
Yeah, this is Phil Nyberg again. Again, sorry for the delay in getting on. There's not a specific number now. There is a concern that some children, some children can be contagious even after their clinical illness ends. And one of the unusual risks seems to be shedding in the feces, that the fecal specimens are positive for longer. So which means really that younger children who require diaper changes are greater risk. But I would I would think that 7 to 10 days afterwards should be sufficient.
Our next question is planning. Is escalation planning taking place, and how can physicians play a role if we need beds, ventilators, masks, et cetera? Is there a point of contact where we can share?
So locally and regionally, a lot of that surge planning is happening through the coalitions that Norm mentioned earlier. So the Central Virginia Healthcare Coalition here in this area is actively keeping tabs on the number of beds and sharing that information, trying to, hospitals have their surge plans in place. So there is a coordinating body, and I'll ask Norm to kind of speak to at the state level what other interventions are being put in.
Thanks, Danny. So as Danny mentioned, the coalitions are heavily involved with working with the hospitals on medical surge capacity. We've set up what's called a unified command structure at the state level, involves multiple state agencies, community partners, including the Virginia Hospital Healthcare Association. We've worked closely with VHHA over the years on planning for pandemic outbreaks and worked with them, for example, in the H1N1 pandemic back in 2009, 2010. So we have real good plans around how to do the medical surge. Currently, in that unified command, we have a work group that is counting all the beds that we have available, looking at excess capacity in hospitals, looking at things like buildings that have been repurposed from clinical to become administrative offices. I used to work at UVA, for example, and the old hospital has a lot of administrative offices now, but looking at those sorts of buildings and thinking about how we can repurpose them back to medical use. We have looked at buildings, transportation, for example, bought an entire building in order to deal with a right-of-way issue, and they're not using the building, so we're going to repurpose that if necessary. And there's other instances like that. So we're looking at that sort of thing and making plans for how we would use it for medical surge. You may have heard a couple days ago that Governor Hogan in Maryland in announcing they was closing down restaurants, bars, and so on. As part of the executive order, he also asked the Department of Health and Hospitals to come up with 6,000 beds. They were able to do that without any new construction. They did that through the sort of methods that I was just outlining, looking at the existing hospitals and their excess capacity and trying to pull that together. And so we're in the process of doing that in preparation for medical surge. I think that physicians in the community who are interested in helping out on that, I think one of the things we'll be doing is, in addition to partnering with the VHHA, we've done our best to partner with MSV and various specialty organizations so that we can if necessary, reach out to private practice physicians to have them involved in this as well as community health centers like the Daily Planet here in Richmond, and free clinics and other clinical providers.
All right, thanks. This is an office-based question. How should we sanitize rooms in between patients to eliminate COVID, since it can live on the surfaces for some time?
The virus itself is not particularly hardy. There's a whole list of approved cleaners that is on the CDC and the VDH website, and so I think just a thorough cleaning with an approved cleaner in between patients would be an appropriate intervention. Melissa, anything you'd add?
Nope, that's right.
Perfect. All right. Somebody asked, what's the possibility of drive-up testing sites being set up in Central Virginia?
So this is happening right now. Today, in fact, the health department is standing up our first pop-up testing site, and we're doing it by appointment. And so if there are any of you who have patients in the Central Virginia region, have them call 205-3501, 205-3501 today. We have a call center in place that will be scheduling appointments for just a little over 100 patients, and this is our first run at it. We're gonna see how this goes. We're gonna test as many people as we can, and the hope is that this model can be replicated across the region and perhaps across the state. The biggest barriers that I think all of us are well aware of is lab kits, test kits, PPE, and then at some point it'll be bodies too. If we have multiple testing sites available, we will need staff to help run those sites. And so, Dr. Deal, to your earlier question about how can docs help, I think there will be a time coming very soon where docs who may not have the volume in their practice, or who may have a day or two a week to give, would be asked to come get fit tested and then help run all day testing. So today's the first day that we're doing that here in Central Virginia. Coming down the pipe, and then, as I said, Daily Planet actually just started yesterday. We also have the hope that, I heard an announcement yesterday that Bon Secours has identified 5 facilities here in the central region that will become COVID-19 testing sites only. I don't know how long it will take for them to operationalize that. But these movements are coming. I know my colleagues at Commonwealth Primary Care have set up a tent testing site in their lot for their patients. And so I think, what's happening is the healthcare community really figuring out how to innovate and meet patient demand, but also preserve the healthcare workforce so that you all can continue to provide the incredibly important healthcare that you're doing in other arenas.
Thanks, Danny. All right, here's a question about, is there a recommendation to limit routine patients coming into the office to be seen?
I have not seen that. Melissa or Norm?
I think, I don't think we've made a formal recommendation to do that. I think as we start seeing, if and when, or as or when community spread becomes more common or more widespread in our areas, I think it is going to become prudent to start to defer more elective visits. And in particular, if you have an older patient population or a sicker patient population, to not to defer elective work or elective visits, to allow them to not have to be out in public as much as possible. But it is not necessarily a formal recommendation that we're making, but I think it would be prudent. And there is some guidance to the end on CDC's website, but I don't think we've said that right now you need to be doing that in your offices, but I think it's something for clinicians to be thinking about as we're moving forward.
One question is, let's extend that to elective surgery. Should we be doing elective surgery, and who at the state makes that decision, and how best to determine elective?
This is Norm. I believe that our healthcare coordination group, working with the hospital association, is trying to come up with some guidance on that. I don't think we're at the point yet where we need to stop doing elective surgeries, but as Melissa was just saying, when the incidence of the disease reaches the point where it's widespread, and we're beginning to see the need for medical surge in the hospitals, I think we'll have to be postponing elective surgeries because we'll be needing those ORs for other purposes. We're not there yet, but I think plans need to be made in the hospitals for that eventuality.
Another mask question. Should we be wearing masks in the office when seeing asymptomatic patients just for routine care?
I can take that. I would not advocate if there is no indication that there are symptoms. I think every effort should be made to elicit from the patient right from the get-go, right from triage, whether or not there are any respiratory symptoms or signs of a febrile illness. But in the absence of those, we would not advise masking up, in particular since there's likely to be a shortage of surgical masks in addition to respirators.
Another question. Oh, sorry, go ahead.
Yeah, how we've been handling this in our local clinics, although we're pretty much scaled down to hardly any clinical services at this point, just given the COVID-19 response. But we've been calling every patient and doing a phone triage before they come in. And I know a lot of practices are adopting that as well. So that may be, again, another way to mitigate exposure to your staff.
Another mask question. It says the N95s are single use, but can we reuse those? And if so, is something we should be doing to clean them, or bleach or spray or something like that?
So there are, good. Okay.
No, I'm pitching to you.
So I'm not at the risk of, I'm not going to go into extensive detail just because there's a list. But on CDC sites, there is a specific area that is dedicated towards optimizing and preserving N95 supply. And they go into some considerations around what you can do to conserve your supplies now, or in the normal state of things, what you can do right now where there's a bit of a shortage, and then what your options are when there's absolutely nothing else to be found and you really just need to protect your staff. And there's different things that you would be doing. There's different thresholds for reuse and repurposing that you'd be using at each of those stages. So I would direct folks to that CDC site on their drop-down list regarding optimizing and extending supply, the supply of N95 respirators.
It's another tracking question. The health department is tracking all positive, tracking the contacts for people who test positive for COVID?
Yeah, that is a huge effort of the local health departments right now. Every person who tests positive, certainly through the state lab, we're notified right away. It seems like the last couple of positives we've had here in Henrico County have been through LabCorp testing. So it seems like that reporting mechanism is working. So we are tracking all of those cases. We are doing contact investigations on all those cases and identifying close contacts who need to be self-quarantined and potentially tested if they're symptomatic.
Danny, do you need to know every person we test or just the positives?
Just the positives.
Okay. Another question is just about a staff, which is a nurse. Sorry, hang on. Let me ask another question. Any advice on setting up telehealth quickly? Any information on where Medicaid will be paying for telephone consults or virtual visits? And the patient's have to sign a waiver acknowledging virtual visits, or can we just let them know?
Yeah, there's a new guidance document on hhs.gov. I can send that link over as well, that talks about telehealth and the prospect of reimbursement. There are a couple of folks, at least again, in my local perspective, VCU is ready to stand up telemedicine. I think they actually pulled the trigger yesterday and have their protocols in place, and so they may be a helpful advisor to other practices about how to do this. And I don't know, Norm, if there's been any other conversation about telemedicine at the state level that you want to speak to.
Yes, we've talked with both VCU and UVA, which have both have very robust telehealth capabilities, and we're in fact, I think later on today there's a meeting with them to discuss how we can stand this up. With respect to reimbursement, with the declaration of the national emergency by President Trump, that allows CMS to relax its requirements around that. And so the Department of Medical Assistance Services here in Virginia, our Medicaid agency, will be changing its regs so that there can be reimbursement for telehealth services. So we want to stand up telehealth services, and Medicaid here in Virginia will be paying for those.
Thanks, I appreciate that. Another question is, if COVID-19 test is done and comes back negative, can the patient end quarantine immediately?
Yes.
Sorry, I was unmuting.
Oh, go ahead, Melissa.
Sorry, I was unmuting or trying to unmute. Yeah, if you have a symptomatic patient who tests negative for COVID-19, we're considering them ruled out.
Next question.
The one nuance I would say to that is testing of asymptomatic individuals at this time is not something to end quarantine is not something we're recommending. So, for example, if you have a patient who's asymptomatic, who's on quarantine, who says I want to test because I want to end quarantine, that's not a practice that we recommend, since that's no guarantee that the next day that they're not just incubating, and the next day they're not going to develop symptoms. So that practice is not one we're doing.
All right. So about 50 people have asked, of course, when are we going to get more tests? That seems to be the $64,000 question.
Yeah, I addressed it a little bit earlier. Again, in Central Virginia, I know LabCorp has about 2,000 kits that they're distributing yesterday, today, tomorrow. But I don't have much clarity on what the national picture looks like in terms of test distribution. Norm, I imagine you guys have been talking about this a lot at the state. Any other clarity?
The state lab should be getting more test kits from CDC. They currently have about 300-400 tests, and that when they get that, which we expect today or tomorrow, they'll probably double their capacity. The national scene, as you mentioned earlier on, we've been told by HHS that there's going to be, well over upwards of 2 million tests available by the end of the week. There's the plans to do the drive-through testing that will be focused on the states that have the are hardest hit right now with the COVID-19 pandemic, like Washington State, California, New York State. We have been told that we would be in phase 2, and at the state level, we're planning out places of dispensing where around the states, so that we can have testing sites set up once we get those things in. But we don't, as Danny said earlier, we haven't actually we don't have those tests in hand yet. So we'll see. We're hopeful that this time this promise of tests is really materialized.
So another question is about if you don't test, if you're a primary care office that doesn't test, where do you send people? Clarify that, please, again, Danny, other than the stand-up drive testing site you're working on.
Yeah, I think until a lot of COVID-19 testing sites are clearly available, the primary guidance would be to stay home and isolate until your symptoms resolve. Right now, you know, we're doing these pop-up sites. We're trying our first today. The Daily Planet has opened up a testing site, and their patient population is primarily the homeless and underinsured. And then Bon Secours has 5 regional facilities that they will be using for COVID-19 testing. So I don't know the exact timeline on that. I don't know when the doors will open on those sites, but that's coming soon.
Another question, this is just about working on telehealth. Could you advise on the specific CPT codes and allowable charges for the extensive phone consultations that are being requested from patients, even if with or without video connections?
Certainly not something we've been looking at locally, and I don't know if VDH has assigned this body of expertise to anybody. It might actually be somebody in DMAS. Norm, I don't know if you know. We might have to get back to you on that question.
Yeah, I don't know the CPT codes, and I would go to DMAS, or actually you could probably reach out to for folks here in the central region, I reach out to VCU telehealth folks, because I'm sure they know how you should go about getting reimbursed.
Another question is, where's your central drive-up testing site?
I don't actually know if we're releasing that, because it's a pretty highly controlled by appointment only. So again, if you have patients that should be tested, call 205. What is the number? 205-3501, and then we'll get them logged into the system, and then give them the access code that they need to get into the site. And I hope you guys understand, just the mass demand of it will make it completely overwhelming. I mean, we're set up with security, and we've been really thoughtful about the throughput of this, but because this is sort of the first opportunity, we need to keep it very regulated so that the staff can stay safe and we can actually get folks tested.
Somebody wasn't really a question, but a comment, just that to keep recommended to keep children getting their well child checks so that we continue to get immunizations to keep the preventable illness down. Do you agree with that, Phil?
Obviously you don't want to have kids miss too many well child checks, but yeah, I think that the fewer visits for any of the kids, the better in terms of transmission within practices.
Again, this is another triage question. When triaging questions on the phone, is it recommended to use PPE for any patient with a cough and fever?
I think we should be doing that at this point, given the degree of spread that we're seeing.
All right, next question is, what is the turnaround time on testing?
The LabCorp testing was at about 3 days. The state testing seems to be
I would actually say it's probably closer to 5 for LabCorp, 4 to 5, just to, or that's what I've seen, and the folks that we've had come back.
But it's our DCLS testing is still sort of 2 days or quicker.
Yeah.
Okay.
All right. Somebody noted that Johns Hopkins was making their own tests. Are MCV or UVA, VMS, or any of the 6 schools making? Are you aware of? Are we developing anything locally here in Virginia?
I have heard some reports that UVA is looking to develop their own diagnostics. Melissa, anything else?
I don't know that VCU is developing their own diagnostics. I know that they're looking to adopt or bring on board the CDC test that is currently being done in DCLS.
Somebody, again, another testing question, just about the sensitivity and specificity of the test.
With the CDC test, it's 95% sensitive, 95% specific.
Okay. Any other drive-up testing sites other than the one that you mentioned already? Are we aware of any others? This is a lot of people are on the call from across the state. Are we aware of anything else? Any other health districts that are going to plan to do a drive-up site?
I am not off the top of my head. I can put a request out to my colleagues today and see if anybody else is working on that.
Yeah, next question is the office-based question is, what are we doing? What should we be doing with staff that are over 65 or high risk or have other medical comorbidities?
I think if in an ideal situation, if you have the staff capacity, I would have them shelter in place. You know, the recommendation that we're giving to all elderly adults at this point is to minimize contact with other people as much as possible. And so I think those particularly working in healthcare settings are at a slightly higher risk just because of who comes into your office. And so if you can have them stay at home and shelter in place for this period of time, that would be ideal. If that's not doable or they don't want to, then I think ensuring that they're in a place they're minimizing contact with patients who are coming in, and then using PPE if they are a direct care provider.
Two other, we're getting close to the end. Mary Beth McIntyre from the Medical Society sent me a note and just wanted to point out that the National Consortium for Telehealth Resource Centers is hosting a webinar tomorrow at 11 on telehealth and COVID-19, and we can forward that link. Also, when we're going to wrap up, I want to remind people that the answer to this webinar has been recorded, and I don't know that we'll have a transcript available, but certainly we can work on that. But if you want to send this out or look at it again, it's on msv.org. Another question was a veterinarian colleague was doing elimination of waiting rooms by having the patients call from their car when they're arriving and then call or text and their exam room is ready. I don't know if that's widespread.
I haven't heard much of that, but that's a great idea.
Next question somebody asked, is the cutoff for high risk 65 or 60?
I've seen both, so I think the federal guidance is 60. I think the state, when we've asked folks to shelter in place, I think that number is 65.
Okay. And then the area code for the phone number you listed, I think we make some assumptions.
Yeah, sorry, 804-205-3501.
And then another question was asking, can you confirm the recommendation to avoid NSAIDs?
I saw one initial report on that 2 days ago. I haven't looked into it anymore. I don't know if any of my colleagues have seen that as well. There's not been an official recommendation from the CDC about that.
Let's see. Another question is, does the MSV or any other group have resources for keeping primary care office open, especially pediatrics, during the next few months when we cannot make payroll due to decreased well child visits?
Sorry, repeat the question. Can the MSV do anything? Is that what they're asking?
Or other groups or VDH is, if you're a small office and our office volumes start to go down, this is going to create a cash flow issue for small practices. And so, is there other resources considered at the state level about how to deal with that?
This is Norm Oliver. At the state level, we don't have any other resources at this point to address that. It's a much bigger question. I know that we're talking to practicing physicians, but as you might well imagine, this is true throughout the entire economy, with restaurants, with parks, with museums, with you name it. This crisis is shutting down a lot of things, and it's hurting a lot of people. I know that the Secretary of Commerce, Bruce Ball, and others are hosting a meeting to talk specifically about the economic impact of the pandemic and how the state can address it. But at this point, I don't know of any specific measures that are being adopted to help physician practices in particular.
Well, I would just, I'm getting a couple of comments about this, and it just is the smaller groups, not excluding the big systems, but live more payroll cycle to payroll cycle based on cash flow, and that this is potentially going to be a big problem with particularly if we start to decrease the normal office volume. The margins are fairly small.
I completely hear you on that, and as I said, that there is some discussions about how to deal with that with physician practices. Restaurant industry, for example, is another one that has very small margins, and it's going to be hard hit by this. So it's a question that is being discussed, and hopefully we can come up with some ideas around this. At the federal level, I know that there is the possibility of getting some stimulus funds through the federal government. There's bills in the Congress that are being discussed to deal with this as well. And I think some combination of federal support and state support will hopefully be forthcoming. I just don't have anything concrete to report on that this morning.
Commissioner,
maybe,
oh, good.
I was just going to say, maybe in more generic terms, I think, like our world has just been flipped on end over the last couple of months, and I expect that to continue for the next few months. And so I think all of us are going to have to figure out, certainly economically, what do we do? And so we've talked about things like telemedicine, phone visits, and there, I do think we're on the horizon of being able to start billing for those, and so that may be one way to maintain a revenue stream for your practice. I just got a text from one of my colleagues, Dave Taminger, who is with Commonwealth Primary Care, and they have adopted a whole protocol for this that I can send out to you as well. But it really is going to require all of our practices to think about other options to keep businesses afloat, or to I know everybody is facing these decisions about, do I have to lay off staff now because we just can't do it? And I think even beyond healthcare, the entire country is in the same boat.
All right, we are at the closing time. Thank you all very much. Thank you, Commissioner Oliver, Dr. Avula, Tracy, Phil. Thank you all so much for coming. We will plan to do this. I've had a number of requests to do this again next week, and we will make the appropriate arrangements. Thank you all very much. Have a great day. Be safe. Wash your hands.
Right.
Thanks.
Thanks for having us.
Take care.
Thanks much.